Welcome to the first webinar of the series 988. It is not just a number. Hosted by the National Academies of Science, Engineering, and Medicine's Forum on Mental Health and Substance Use Disorders. I welcome our virtual audience and those viewing the recorded webcast today and on different days. I'm Margarita Alegría, Chief of the Disparities Research Unit at Mass General Hospital and Mongan Institute, and I'm a professor at Harvard Medical School. I, together with Howard Goldman, I'm the co-chair of the Forum of Mental Health and Substance Use Disorders. Although this will be a virtual workshop, it is being hosted from a physical location in Washington, D.C., the home of the National Academies and the Forum. Therefore, I would like to acknowledge and offer our deep gratitude and respect to the Nokachkatank, Piscataway people and elders and ancestors, past, present, and future, everywhere in the United States, territories, and jurisdictions where our speakers and attendees find themselves. They are on the land of Native American tribes and people. The Forum on Mental Health and Substance Use Disorder provides a structured environment, a neutral venue to discuss data, policies, practices, and systems that affect the diagnosis and provision of care for mental health. In addition to exploring innovations to improve access to quality care, such as the access to the new National Suicide Prevention and Mental Health Crisis Lifeline, 988. 988 launched in July 2022, offering 24/7 call, text, and chat access to trained crisis counselors who can help people experiencing suicide, substance use, mental health crisis, and emotional distress. The main goal throughout this webinar series is to highlight the best implementation practices, discuss challenges openly, and propose solutions to overcome difficulties in implementing or gaining access to the lifeline. A special thanks goes to Stephanie Barrios Hepburn, Brian Hepburn, Mike Hogan, and Michael Scher, Howard Goldman, for helping plan this series along with the NASEM, National Academies of Science, Engineer, and Medicine staff, Ali Andrada, Isaac Su, and Anisha Wilkes. During today's webinar, we will begin with Mrs. Laura Evans, Framing the Key Issues, a presentation by Dr. Anita Everett from SAMHSA on financing 988. Mrs. Marie Kiliverti and Dr. Brian Sims will provide a deeper dive into the sustainability of financing. And then we will hear from Dr. Otto Valdez from the Agency of Healthcare Research and Quality on the importance of cultural competency and humility in 988. Mrs. Andrea Dennis will discuss the role of law enforcement in the context of 988, followed by an audience question and answer moderated by Dr. Cheryl Boyce from the Common Fund. Dr. Howard Goldman will adjourn the event at 2:30 with his closing remarks. I just want to let everyone know that full bios for our presenters are posted on the event page. And please join the live discussion throughout the webinar by submitting your questions in the question and answer box. I will now turn to our first presenter, Mrs. Laura Evans.
Great. Thank you so much. And thank you to the Academies for having us today. If we could go to the next slide, I will begin to just provide an overview for the Lifeline. There we go. Hopefully you all can see me. And I want to start with the disclaimer that the views, opinions, and content expressed by Vibrant, who serves as the administrator for the 988 Suicide and Crisis Lifeline, are not necessarily those of our federal partners. So if we go to the next slide, I just wanted to start again with this overview of what is the 988 Suicide and Crisis Lifeline. You may have heard that that number launched in July 2022, but it actually builds on a foundation that has existed since 2005 and even in a different form before that since 2001. So it builds on the foundation of the National Suicide Prevention Lifeline. And that was formerly a 10-digit number, 1-800-273-TALK. And there was a recognition that when a person was in crisis or that their loved one was in crisis, it's really difficult to remember that number. And so having a 3-digit number like 988 would allow more people to access the life-saving resources and effectiveness that we know the Lifeline and the trained counselors provide. So there are 3 ways that you can access the 988 Suicide Crisis and Lifeline. That's via voice call, text, or chat at 988lifeline.org. And again, when you place that contact, and contact refers to all 3 modalities, you will reach a trained crisis counselor. Next slide, please. So I wanted to talk through briefly the routing structure for voice calls. And so the Lifeline does not have what is called geolocation or location information. So when a person places a call to, or a voice call to 988, they hear a greeting. And that greeting says that if you're a veteran, you can press 1, or calling in regards to a veteran, you press 1 and you're taken out of the Lifeline system and transferred over to the Veterans Crisis Line, which is completely run through the VA. You have the option to press 2 if you are a Spanish speaker or prefer to speak Spanish and you're routed to our Spanish subnetwork. Currently, we are piloting additional options, pressing 3 for LGBTQ youth, and as well as a Native and Strong line for Washington State. So if a person does not press any of those options, they are routed to the center serving their area where their telephone was registered. And that local center has about 60 seconds or so to answer that call. If for whatever reason that local center is not able to get to the call, perhaps all the counselors are on the line, then we also have a national call backup network. That's a collection of, right now, I believe around 20 centers or so who have additional capacity across the country. And so you're able to have your call answered by one of those centers. And while they're not in the local area where your phone number was registered, they're still able to provide those interventions to help de-escalate the crisis. So just a little bit of information about the network. There are over 200 crisis centers in the network. That includes crisis centers that are certified community behavioral health center clinics, so CCBHCs. All of these centers are currently independently owned and operated. So Vibrant, as the administrator, we do operate a center based in New York, but that is just one out of that network of over 200. Since 2005, the crisis counselors have received over 23 million calls, so just calls. And then if we look at the volume during this transition time, we saw over 96,000 calls, chats, and texts come in as we were making that transition from 1-800-273-TALK to 988. So I think that demonstrates the value in having better access to Lifeline interventions through a 3-digit number, and in turn reducing that stigma around calling a suicide prevention line or other stigma that may exist around mental health crisis. Next slide, please. I want to go into a little bit about how our chat system works. Again, for folks who may be unfamiliar, you can go to 988lifeline.org/chat, and then you're asked to complete a short survey so that the crisis counselor knows a little bit about your current situation. Hopefully right now our chat service is through, again, a national system. But we are working very closely with those local centers to ensure that they are building out and have the guidance for taking on additional chats and texts that come in from individuals who are in their area. And so once that individual fills out that survey, they see a wait time estimate that allows them to see how long it will be before they're connected to a crisis counselor, and provide other options either via phone or text, as well as what we call our safe space for individuals to get resources to help de-escalate their stress. There are several activities that can help that caller calm themselves while waiting for a crisis counselor. And of course, again, they have the other options to reach out for assistance. Next slide, please. And again, it's very similar for the text program as well. Texting to 988 into the Lifeline began relatively recently in 2020, I'm sorry, and then has since grown to be a full-time option for folks to reach. And again, this is a nationalized service, and we're working with those local centers so that they can take some of those texts coming in. But again, you complete a short survey, and then the crisis counselor is able to have more information. The texter knows about the wait time that will exist and other options for reducing their distress or reaching a counselor. So if we go to the next slide, because I think this illustrates what happens during that call, chat, or text. And so this occurs no matter what modality that a person utilizes. But that crisis counselor, again, they are trained to connect with the caller, again, empathetic listening, assessing if they're at immediate risk. All crisis counselors ask if a person is thinking of suicide or harming themselves. And then this part here, this in green, this is sort of where the magic happens, because the counselor is listening, they're clarifying, they're safety planning with them, and it's an evolving conversation. It's not just a checklist that can feel really informal, but it's really about empathetic listening and helping that individual feel supported and cared for. And then as they are wrapping up, in most cases, offering follow-up if it's appropriate. That looks like, can I call you tomorrow? Or I want to make sure that you make the appointment, so I'll check in on you, and wrapping up for the call. I'll talk about this a little later, but for the majority of contacts coming into the Lifeline, the individuals are able to have their distress de-escalated on that conversation, either call, chat, or text. And so a small percentage of contacts to the Lifeline involve an in-person intervention. So someone going out to that person to ensure their safety, although it does occur. Next slide. I want to also talk about the most recent data that we have seen come out for the Lifeline. We're also preparing a 6-month review analysis of the data. But for the month of December, what we saw for the Lifeline was that we had approximately 371,000 contacts, again, calls, chats, and texts to the service. And that represents, if we compare it to December 2021, a 48% increase in chats answered, a 48% increase in calls answered, a 263% increase in chats answered, and a 1,445% increase in texts answered. That also represents a little bit more than 172,000 more contacts to the Lifeline compared to December 2021. And so this program, again, has been around since 2005. And when we look at the 2005 investment that was made for the Lifeline up until very recently, this program was operating on $7 million annually for the entire country for a whole year. As you can see, there has been recent, or you may have heard, and I'm sure my colleagues will go into it, there's been more recent investment into the Lifeline. We've scaled from 7 million to 32 million. And then most recently, the FY23 budget that was signed by the president allocates 501 ish million dollars for 988 and crisis services through the 988 Lifeline. And that's a major increase. And that return on investment allows us to get to these contacts faster. We're able to incentivize crisis centers to hire additional staff, to focus staff that are solely answering these calls versus other lines of business they may have. And so when we see that level of investment, we can see that we are getting to these contacts faster. So the average speed to answer across all contacts decreased from 172 seconds to 44 seconds. You can see we're at a 99, 96% answer rate for chats and texts. Again, that's phenomenal considering that these are more recent modalities for us. And even a year ago, were much lower. So we're very proud of this. And I do want to note that this data does include what we've estimated has occurred because the Lifeline did experience a brief outage. The technology provider did experience a brief outage. And so from December 1 through December 2nd, as you see noted on the slide, there was a brief outage. And so we've estimated what those contacts were. Next slide, please. I wanted to also talk through the 911 relationship because that's very important. We have estimated that there are a number of contacts that are going into 911 currently that are best suited for 988. These are contacts that are purely behavioral health, involve no public safety component. And so Vibrant has worked very closely with NINA, the National Association for Emergency Number Administrators, on this suicide crisis line interoperability standard that was released in March of last year. And this ensures that the 911 jurisdictions and public safety answering points are aware of the crisis lines that may be in their jurisdiction. All of the crisis centers in the 988 Lifeline network know how to transfer calls to 911 if it is required. Right now, well, previous to the transition, there was about a 2% of contacts to the Lifeline required that public safety intervention. And so we're going over to 911 for either emergency service, law enforcement, or other deployment. We hope to that with this standard, there will be more transferring, particularly from 911 calls that are better suited for 988, sending them over so that they can have that health first approach. Next slide. And with that, this is a slide that has been augmented, but has been used in courtesy of Crisis Talk and RA International based on research out of Arizona. But our hope is that as more folks are aware of 988 Lifeline and are utilizing the service, that they are able to call that line as needed in lieu of 911, which may not be appropriate, have that resolved by the crisis center. Again, 98% of contacts to the Lifeline previous to the transition were resolved on the phone. And if for those 2% that aren't able to be resolved in lieu of law enforcement or other public safety interventions that may not be appropriate, having mobile crisis teams sent out. Again, majority of our centers are aware of mobile crisis teams in the network. Some of them even have agreements with them, but mobile crisis teams aren't built out in every community. And so that's something that will need to be built out as part of the continuum. And again, just keeping folks thriving in the community, reducing the use of jails, emergency departments, hospitalizations when they're not appropriate for people who are experiencing crisis. Next slide. And then I just wanted to kind of look ahead. We are always thinking through how are we making sure that 988 is accessible and equitable for folks. Again, we have that LGBTQ youth pilot, a Native and Strong Lifeline in Washington State, guidance on specific populations for crisis counselors. We have rolled out this fall additional training courses that are asynchronous for crisis counselors so that they can build their cultural competence and cultural humility, enhancing our data and technology so that we are speaking the same language when we're talking about contacts received and outcomes, and hopefully being able to make that connection so that we can say that contact in 988 did lead to better outcomes. So we're always thinking through that in welcome partnership. Next slide, please. And then just thinking through that suicide prevention is everyone's responsibility. These local centers for a long time have been operating on shoestring budgets, right? Doing this work because they believe in the mission, even when, this was a $7 million program, which, as you can imagine, spread that across the country does not mean these centers were well resourced to do this work. And so we have a page on 988lifeline.org where you could find your local center, consider volunteering or supporting them. They often have fundraisers, or they do other prevention education in schools, talking to your state and federal policymakers on the importance of funding and suicide prevention and crisis services so that we're better serving individuals. And then, of course, sharing accurate information. We have seen with social media, sometimes misinformation can go viral. So always being sure to share accurate information. We have social media shareables and others on our site, and I know SAMHSA does as well. And so if you go to the next slide, you'll see just some quick links for, again, some of those resources: a Spanish and English social media kit, messaging framework, newsletters, job opportunities. So I just want to thank everyone for your time, and hopefully that has set the stage for the 988 Lifeline. And so I'll turn it over to my next colleague.
All right, so thank you very much. Thank you, Laura, for that overview. And I'm Dr. Anita Everett. I work as the Center for Mental Health Services Director in SAMHSA, and SAMHSA is the agency where the government entity within HHS that is where the seat of the 988 and related crisis services come from. I use she, her pronouns, and I professionally identify as a community psychiatrist. Next slide. What I wanted to do, Laura's referenced the timeline. The importance of this slide for me is to make this audience aware that this is part of a continuum. We use terms like launch as of July of this past year, 2022. What we mean by that is really a transition from the number and services that were available by dialing the previous suicide talk line to this 988 and crisis services. Let's go on to the next slide. One of the things that's important for me in sort of laying some of the groundwork, or from our perspective at SAMHSA, is to have us think of this call component as one of three broad components. And so we envision this as a continuum that has three distinct elements, those elements being someone to talk to, and that's primarily what Laura has talked about and what her agency has a relationship with SAMHSA to support. We also have envisioned someone to respond. Typically, that takes the form of mobile crisis response units, ideally with behavioral health trained individuals that are able to respond. Peers often are involved in that. In some communities, of course, that's law enforcement or various forms of combined law enforcement together with counselors. And then third, a component for those who need it or whose situations are not resolved by earlier interventions is a safe place to go for help, which of course could be the emergency room, could also, and increasingly we're seeing the development of crisis receiving units, which are more equipped to manage the situations that come up in the space of behavioral health crisis compared to everyday emergency room style interventions and or inpatient care. So this concept of this horizon and these three elements is important. One of the analogies that we think about is the development of 911, which has taken us about 60 years to manifest itself or to get to the state where we are right now with it. So still not a perfect system, but much better than it was even 10 or 15 years ago, 911. And in many ways, we envision the future of 988 as being analogous to 911 development. Next slide. More specifically, some of the ways that SAMHSA has funded or supported, aimed to develop some infrastructure to support this entire continuum, these three components. You see in the middle there, the money that largely has gone to, that Laura was speaking about. This is to support the lifeline itself, to build up infrastructure, the technology, as well as the people, which, as Laura referenced, was in many communities staffed primarily by volunteers. And we've really tried to infuse enough funding to have a mixture of volunteers, peers, and professionally trained or credentialed staff man those call centers. We also fund a grant series we're now in our second year in the Omnibus Act that passed in December of 2023 or 22. Sorry, I have mental health crisis response grants is a new series for us, and that is to give communities the opportunity to develop the second component of those three components. And then I'm going to talk in a little more detail about some of the resources that are associated with the mental health block grant. The set aside, there is a set aside. The block grant is money that comes to us from Congress and is distributed to the states based on population as well as prevalence of mental illness in the state. And within the dollar amount that's sent to each state, there's a set aside that at least 5% of that amount has to be spent to support the development of crisis services. Next slide, please. So these are just some examples. Of course, I'm not going to go through every one of these, but just to let you know how the states are using that 5% set aside, and we're about to begin our third year of that now. And so there's crisis prevention to develop. We've divided this again into those three broad sections. So some states have worked on a model of manning their call line to develop what's called what's the sort of a model of air traffic control. The third one down there. That tracks responses of response call-ins and responses and outcomes of individuals across the entire spectrum of services. We have the next column over, someone to respond. You see just examples of different styles of enhanced response that includes behavioral health trained individuals who can respond on site in a situation that needs an on-site response. And then the third of these is a place to go. And we are, increasingly seeing states interested in forming community alternatives to emergency room staffing or emergency room presence there. Next slide, please. We also have another series of funds that are opportunities for states, and these are largely managed through a relationship that we have with the NASHMA, the National Association of Mental Health State Program Directors. And this provides opportunities for states to work on areas and for the particular areas that we identify as priorities. And to give an example of some of these that were attended to or addressed in 2022, we had funding that went to develop crisis services in special populations. And what you see there, the listing for Arkansas, for instance, is that they chose to work on LGBTQ and fitting or working their crisis response continuum, all three of those elements, so that it's suitable for or equipped to serve LGBTQI individuals. And another one of those is a workforce and crisis services development, and this is to give states funding to train individuals to work in any one of those three elements. So Mississippi is a state that took advantage of that and has received some funding to do that. And then a third area that we identified that year as a priority is children and adolescents in crisis services development, which some communities are large enough to have a separate line of services. Ultimately, we would like all communities to have staff that are equipped to understand some of the differences that occur in crises when they occur with children versus crises in adults. And so you see there, New York is an example, for instance, of a state that took advantage of that opportunity to develop its crisis services. Next slide. This is just a listing of other types of documents that you can have. Some of these are available on our website, some on NASHBID's website, or majority of them actually at this point are these documents are on NASHBID's website. The one I have there is one I wanted to call particular attention to, and that is a very new one that we created that is a document on children and youth behavioral care crises. Next slide. I would be remiss if I didn't talk about one perspective that we have at SAMHSA that's a very important program to us right now, and that is the Certified Community Behavioral Health Clinic, a series of programs. I know you'll have access to these slides as a part of your attendance today, so I'm not going to go over the details of these slides, but what I did want you to notice in this program, and this is a program that largely will, we have over 500 grantees nationally, as a part of this program, and these are growing. They've had quite a bit of congressional interest, and they're up-funded every iterative budget that we've had in the last several years. But they do require a focus on availability and accessibility of services in outpatient settings. That's the point 2 there that's yellow highlighted. And they also have a required element of crisis services and access to outpatient mental health substance use services. We require that a routine outpatient care be seen within 10 business days of the initial contact with the individual seeking services. Next slide. This is just an idea of where the states are. So most states by now, the majority by far and away, have had experience with one or more CCBHCs. Next slide. And this is my final slide. I would be remiss as a community psychiatrist if I didn't call attention to the fact that this is the 60th year anniversary of the original President Kennedy signed into law the Community Mental Health Center Act on October 31st, 1963. It was the last act that he signed before he was assassinated. This act provided $325 million for mental health programs, and that may not seem as much today as it did, but I did a rough back of the envelope calculation that if you consider inflation, that adds up to about $3 billion now, which is really on scale with the current CMHS component of SAMHSA's budget. So this was a landmark contribution to the startup of community mental health centers in the United States. That being said, the community mental health center system, many individuals have described it as very fragmented, and that's because in some places is much more developed than others. We see the CCBHCs as having the potential. The CCBHCs coupled with the crisis services system, those two elements as being a complete game changer for the public mental health system or services system in the United States. We see those two programs combined, crisis combined with accessible, high quality outpatient services as being very much potential game changers. And I want everyone to have some awareness of those two activities which are related to getting people into services faster and better. So that is it. And I'm happy I've answered a few questions in the chat and I'll be attending the chat and staying for the rest of the time for other questions. Thank you very much.
Hi, I am Mary Giliberti. I am the Chief Public Policy Officer for Mental Health America, and I use she, her pronouns. And I have been asked to speak about financing. And we all know no money, no mission, right? So that's the issue here, right? If we don't have money, we have no mission. So I'm going to talk about sustainable funding, state laws, federal appropriations, and insurance coverage, because everybody's got to pull their weight if we're going to realize the promise of the 988 system. So next slide, please. So first, I'm going to start out with states, because the federal legislation that created the 988 number allowed states to have a fee on cell phone bills and other telephone bills to finance the system. That's the way 911 is allowed to be financed as well. And you see here about 5 or so states in gold. And those are like the gold star, like we used to get in elementary school, because they have comprehensive state statutes. And what does that mean? What makes it comprehensive? It is comprehensive if it has an oversight body, it has a plan for what services are going to be provided, it has a fee in it, and then outcomes. So kind of a comprehensive plan there. And some states also have some provisions around Medicaid. Now, so I talked about states. I'm going to talk a little bit about federal programs. Medicaid is the state federal financing system, covers many people with disabilities, many people with low income, very important funding source for crisis services. And some states have enacted legislation that expands their crisis system using that funding source. You see there about double, like around 10 or 11 or so states are in green. They have partial statutes. The gray is folks that haven't really done much yet. We're still hopeful. The purple is where states have not passed legislation. It was pending. So we had legislation, but didn't get all the way through. And the light yellow there is pending currently comprehensive legislation. And the light green is pending partial legislation. So all of this you can find on the website on the bottom, which is reimaginecrisis.org. Reimagine Crisis. Because really, that's what we're all doing with 988. We are reimagining this system to be much more responsive, to have a behavioral health response to crisis, right? Instead of a law enforcement response. And that in and of itself is fundamentally about equity for people with mental health conditions, and particularly for people of color, right? And so I also just want to say, I know Brian's going to cover it in much more detail, but as you look at these statutes, some of them in states really address equity. So they make sure that when they put into place mobile crisis teams, those teams are specialized to serve particular populations, and that's very important. So equity overall is a theme that you want to be looking at when you look at these statutes. We do have a model statute. So as I said, you see a lot of gray there, folks. So there's a lot more work to do. And we have a model statute as well as these examples. All of that can be found on that web page maintained by my friends at the National Alliance on Mental Illness. Next web page, please, PowerPoint page. So here I'm going to talk about federal financing. I'm going to switch over. I talked a little bit about states, and that's important. That's one leg of the stool. Now we're going to talk about federal financing, and there's different pieces of that. There's money that Congress allocates, okay? And so in the summertime, we had the Bipartisan Safer Communities Act. You see me and my colleague in front of the White House, nice sunny day. And that allocated $150 million for the Lifeline, $250 million for that block grant that Anita talked about, and also had some money around school mental health personnel and pipeline money for school folks who can provide mental health services. Why am I mentioning that? Because in this presentation, I was asked to speak about 988 financing, sustainable financing. But I do want to mention that crisis is not a win, right? We ultimately want to prevent crisis. And so in the future, I hope we will do a lot of work strategizing and talking about how to finance the services that will prevent crisis, how to measure that and make sure that we can limit crisis. Right now, we're in the process of building up our crisis system, and that's what I'm going to talk about. But we need a complementary strategy to make sure that people don't go into crisis. Next slide, please. So the omnibus, Laura mentioned it, Anita referenced it as well. Every year, Congress passes a bill that funds the government, right? Every year. And there's money in that bill for different things. And we have to advocate for it every year. So the benefit is it happens every year. Pretty much Congress will not go below the year before, you hope. And then you try to build on that and get even more, right? So last year, the block grant went over the $1 billion level, which was wonderful, had that 5% set aside. We had that money for the crisis pilot response that Anita mentioned. The Lifeline got up to over $500 million, with $30 million for specialized services for underserved populations. And then money for community behavioral health clinics that provide crisis services. You heard about those. And then a coordinating office at SAMHSA. So those are things that were in last year's bill, and we're going to be fighting for in next year's bill, hopefully trying to increase those. Next slide, please. Then in the omnibus bill this year, in addition to those every year dollars, we had policy changes that were very important for sustaining 988 over the long haul. So you remember I talked about that three kind of a multi-layered stool, if you will. So we have the states, we have federal appropriations. We also have to look at insurance programs. That's Medicare, Medicaid, and private insurance. So in Medicare, this is the program that covers older Americans, and some people with disabilities in the United States. That program now has changed due to this bill to cover more folks. So it covers marriage and family therapists, licensed counselors. It had additional psychiatry slots. CMS was told to provide guidance on how peers can be billed as auxiliary personnel for mobile crisis. So peers have not been covered by the Medicare system, and now there's ways you can cover them as auxiliary personnel, meaning part of a team in this case, or working with a billing provider. There's a new Medicare service called Psychotherapy for Crisis Services. We think that's a fancy way to say mobile crisis services. We will be seeing how CMS is the agency, the Center for Medicaid and Medicare Services. They are the chief financing agency in the HHS. So very important agency, and we'll be looking to see how they define these services. Next slide, please. Medicaid, that's another important funding source I've already discussed. State and federal both contribute dollars to that program. So this bill that was passed said that HHS will issue guidance to the states on funding authorities, on best practices, on all kinds of information. They will establish a technical assistance center to help the states. They will issue a compendium of best practices. They will, the Lifeline Improvement Act was also included in this bill. That's not about Medicaid, it's separate, but it's about the Lifeline Laura talked about. And there were new requirements for follow-up care and for outreach. Why is that important? Because with new requirements, we're going to need new money to go with that. The bill also authorized that set aside in the block grant that Anita talked about. So it was a pretty comprehensive and important bill. Next slide, please. Just to talk a bit about Medicaid, because it is such an important funding source for sustainable crisis care. So the American Rescue Plan Act, which was passed last year, provided additional federal matching percentage for mobile crisis team services. So you got a higher match, meaning the federal government pays more, states pay less for mobile crisis teams. So that was very helpful. So in your states where they're trying to build up these teams, this is something to take advantage of. It gives 3 years of additional funding per state. So Medicaid can cover pretty much the whole continuum under the rehabilitation services option. But did you hear me say option? That means every state gets to choose how it's going to do that, what it's going to cover in that. And reimbursement rates are very low in Medicaid, which is just something to be very aware of as we go forward. Next slide, please. The last piece of the funding sources is private insurance, right? In order for 988 to be successful, everybody has to do their share, right? Including private insurance. But most plans do not cover crisis services. And we and others have talked about a parity argument that mobile crisis should be seen as emergency services and should be covered under the marketplace plans, the Affordable Care Act plans, and employer plans. So states have started to do this. And you see there, Washington has a bill, 1688, that defines crisis providers as all licensed providers, whether they're in or out of a facility, and they require coverage of behavioral health crisis services. So that's very helpful to ensure that all of the different insurance programs do their share. Next slide. So looking ahead, we expect that the House is now a Republican, the Senate is Democratic, and spending, we anticipate that there will be some pressure to reduce spending and increase oversight. And we also expect the same interest, if not more, in mental health and substance use, because the data has not changed. We still see a tremendous need out there. Next slide. So the administration will have a new proposed parity rule that's already been talked about. It's in the OMB list of kind of rules coming out. So we're excited to see that come. Hope it will address crisis. More Medicaid and Medicare guidance, which I talked about, a new technical assistance center, continued disbursement of funds, continued advocacy for the money in Congress, increasing to fund all the things that I mentioned, increase awareness, follow-up, equity, and oversight of 988. Next. So that's my contact information there. And again, just, as we look to 988, the promise of 988 will depend on whether we can get all of these systems to pay their share and to have comprehensive funding for mental health care and 988 so that a behavioral health crisis can get a behavioral health response. Thank you.
Hoping that everyone can see the slides here.
Yes.
And just like to thank everyone. With all of the previous speakers, it really puts a pressure on where we're headed next. But I'm so thankful for what has been delivered so far. I'm Dr. Brian Sims. I am the Senior Medical Advisor with the National Association of State Mental Health Program Directors, an organization that for the past 60 plus years has been working directly with the states, territories, and other jurisdictions in the District of Columbia, and working with the behavioral health commissioners on delivery of behavioral health care. And we have been intimately involved with SAMHSA and their efforts, not only in the launch of 988, but also taking a look at its implementation. And I wanted to drill down a little bit further because with the wonderful interview and the overview that you've had so far with regards to the funding, with regards to the availability, what I wanted to do was drill down a little bit more and talk about the sustainability elements of the 988 funding. In order to do so, we also want to acknowledge that the challenges that come with this are pretty high. But I also, on the same positive note, would like to outline that many of the states that we work with regularly, and we have regular contact with all 50 states with regards to their provisions of care and implementation strategies, have done a pretty incredible job of moving the needle forward. What you've heard so far since the inception has been the tremendous overlay of equity, making sure that equity is woven into everything that we're going to be talking about. And even in the sustainability piece, you can rapidly see how equity is a very important factor to consider when you're implementing elements that are going to sustain your services going forward. So I'm going to talk a little bit on that. And what I'll do is, first of all, with the disclaimer, and we'll get that piece taken care of. But I wanted to start first with a document that you may have in your possession. And this really came from the SAMHSA 988 appropriations report that was given back in December of 2021. And I chose this particular page because it has woven into it the kind of mission that the states have had to take on and how they have perceived it, and what the challenges were in terms of not just looking at sustaining, but looking at sustaining in an equitable fashion. And that has become the overall challenge, because as you go through each of these measures, what you begin to see very quickly is providing access to everyone. That is looking at equity through this 3-digit number. And that may seem on the surface like, it's not a really big deal. But how do you reach everyone? You reach individuals that are vested, but how do you reach people that are not vested? How do you reach people that are unreachable because of distances or Wi-Fi signals or otherwise? So the 3-digit number piece becomes a piece where the equity gets woven into that particular portion. Then we look at the reliance of reducing the reliance on police forces with the mobile crisis teams. That again is not just looking at a static element, it is looking at a very dynamic and forward moving component. You want to reduce the deadly gaps in the fragmented behavioral health system, because the states have reported to us regularly that in many of the systems that they encounter, there's so many layers that many people will drop out before they even go through that crisis or go through and follow through with whatever services might be available. So in this 988, the states have been given the challenge of not only how to weave through and simplify the process, but to how to sustain it and continue it on so that all persons can get the same level of service at the same degree. The other piece that's been reported to us regularly has been about emergency room boarding. And this is a particular problem for a lot of states because they're seeing many people boarded up in the emergency rooms who can't move on to other elements. And it is the worst place for them to be held in. So looking at community placement as a part of it is, again, that sustaining component. Because sometimes when we have services, we do the services up front and we take a look at what services we have to offer people in the beginning. But once they're released, there's little or no follow-up. So you also want to weave that in and recognizing that the funding is inadequate to do all of the things. Some states have been very creative about how they've been able to move in that direction. And lastly, to meet the behavioral needs of all people, keeping the equity lens in mind, that are experiencing a crisis in a way that is going to reduce that stigma. We talked about earlier, you've heard about marginalized communities, communities of color. We know that there is a different lens that is possessed in terms of trusting the mental health system, looking at the system as something that they would want to embrace or would want to go away from. And looking at a sustainable component, how do we involve them so that they're better involved in the future and will want to seek the sources? So these are challenges that the states have had, and we've had some pretty amazing responses. Now, I don't have time to go through every state that has done a wonderful job, but what I wanted to do is just talk about two in particular. One is Washington State. And I love working with these folks in Washington State. And if there's anybody on the line from there, kudos to all of you guys. But it is not to put you at the top of the pedestal because many states are doing very, very good work. But Washington State was one of the first states that enacted legislation that put that fee in there. And we realize that every state does not have that fee legislation, but it is a very good first step to kind of incorporate looking at not only sustaining your services, because again, your funding can be front door, but how are you going to continue it therefore? How are you going to pay your staff? How are you going to go through the processes that are going to deliver the level of increasing care that you're expecting to occur? So in that sustainable format, having this funding has been able to really come back in a very large element because they were looking at it as roughly with this $46 million annually that would help them to be able to cover what it is that they are doing. Now, also in terms of looking at it from an equity lens has been the state's efforts with regard to looking at tribes and looking at the Native American populations to ensure that there is equity across that lens. And Washington was one of the ones that looked at it from involvement because, you know, there's the statement that says, nothing about us without us. You know, and in the case of the tribal nations, it really was powerfully placed in a very much forefront line that if you're looking at sustaining services, you're looking at providing services, you also have to look at the uniqueness of the community. And Washington State actually was one of the states that actually developed a subcommittee, a tribal subcommittee. And these are individuals that come to the table and not only give you what the community's needs are, but also give you forwarding information in a sustaining fashion to tell you what the needs are going forward. So this was a really, really nice move on their part. What Washington State also did, and there were multiple things that I can't go through every single one of them, but was to go in and take a look at their infrastructure. Because as I mentioned before, the fragmentation that was taking place across a lot of other systems, they took a deeper dive to take a look at it. Because what they wanted to do was simplify the navigation process, make it as simple as possible. There have been other states that have done incredibly good jobs in that. Oklahoma has been one that has implemented iPad systems to really kind of help with simplifying that process, but it's another wonderful move. Another is to take a look at the enhancement of the crisis response services. because what this did was these call centers were able to triage the calls and get people quickly linked to care. I know that this is a goal that all of them are possessing, but it included in the Washington example, a 23-hour stabilization unit, and where you're looking at not moving people on, but ensuring that they're going to go from one service into a service that is going to be most beneficial to them, whether it's involving a peer-operated respite service or looking at walk-in urgent care centers. But what it did do was establish the concept of the quote unquote no wrong door to ensure that anyone who is in need, keeping the lens of equity in mind, anyone who is in need can receive that level of care that they need. Lastly is to take a look at the service fee again, because with the Washington example, that service fee has been able to really tie in to not just looking at providing services of a nature of direct care services, but also looking at what things also need to grow with the system, to be sustained with the system, which is looking at your radio access lines, looking at your wireless landlines, even looking the voice over internet protocol services. Because what you're doing then is creating more services of a broader sense and a technological advancement that is going to continue the sustaining quality. Now, the other example that I'd like to present comes out of California. And they're very similar in one sense, in that California is another one of the states that Mary had presented earlier that has been able to get the legislation passed to be able to get that funding, because that funding came through California as part of the Miles Hall Lifeline and Suicide Prevention Act. And in that, it starts off with sustained functioning. What you're talking about is having that funding available to you going forward in a sustained fashion, and how you use it then would be able to start looking at all elements, looking at all treatments, to be able to not only fund your present services, but take a look at moving forward. And in this legislation, what you see is that they actually sit down at the table and they talk about the plan, not just as a static, here's where we are, but let's plot out the next 5 years. And let's take a look at the metrics, the likelihood. And as you probably have heard before, when you've seen one community, you've seen one community. Well, when you're looking at the states, it's very much the same way. The legislation might be different, but if you're going to sit down for a long-range plan, you're really talking about the uniqueness of your long-range plan, focusing again on equity, to ensure that the provision of care is not going to silo anyone, it is not going to move anyone into pocketed areas, but is all inclusive. And this can be through multiple efforts that they've seen. In addition to comply with these changes, they actually sign on to taking a look at establishment of a group of stakeholders. And this is something that many of the states are beginning to embrace at an ever increasing level. If you want your services to be sustained, if you want them to continue over lengthier periods of time, you have to involve the people that you are serving. Go into their communities, take a look at your county behavioral health people, look at your law enforcement people, look at the agencies that are in the community and bring them to the table. Because what they bring to the table is knowledge of everything that is going on within their communities, and they can be guides to you. And what California did was put them all at the table and said, okay, just like with Washington State, let's now talk about what kind of movement we can get over the next 5 years. Now, I understand, as I mentioned before, that this is really, these two examples are based highly on the acquisition of this 988 service fee. But many of the states are finding ways to do things internally, either working with the local legislators. In one state, they're actually using a very friendly legislator who was speaking on their behalf to the remainder of the legislature to get funding released. There are many different options that they've been utilizing. The other thing with California is the establishment of culturally sensitive counselors. Because in an equity fashion, you have to understand that many of your workforce individuals may not be sensitive to the needs of the various communities. And what they've been able to do is to take a look at this and start to place in place these culturally sensitive counselors. A good example of it is the pilot program that they released to connect people who were specifically trained to work with special populations like the LGBTQ youth. And this is through the Trevor Project, which is a noteworthy organization for LGBTQ youth that is crossing over various states and are used by a number of systems, but it opens that lens again to a conscious understanding, not only of the needs to address the population, but how to do it in a fashion that is going to be highly sustaining. Now, Governor Newsom out there had placed also some funding to go towards the first responders. And this is something that the states are beginning to take a look at. As we may not have talked about, but a lot of it has workforce issues that are very clearly outlined, that police officers and so forth do have problems with regards to mental health issues and so forth. So this funding is to really provide preventive care for them, and a peer-to-peer suicide prevention curriculum was also established for them. And then finally, what I want to do is take a look at this little piece here that really talks about the appropriation, the same appropriations report, the highlighting in red that while the funding may increase, you want to take a look at that future, looking at developing a partnership that is going to be focused on sustainability and service integration, because you don't want your system to go backwards. So I thank you all very much, and I'll pass it on to the next speaker.
Good day, I'm Robert Valdez. I'm the director of the Agency for Healthcare Research and Quality. And today I'd really like to talk about the main mission that we have at AHRQ, which is to produce the scientific evidence and knowledge that's required to improve healthcare in our country, both physical healthcare and mental health care. And in particular, I'm really happy to be working with our colleagues at SAMHSA to reduce that dichotomy between mental and physical health care. Our job is really to produce that evidence. So I hope that those of you who are in the audience who are health services researchers will consider submitting proposals to AHRQ to support the research that's necessary to make the kind of healthcare services along the continuum from crisis to continued care of higher quality, more equitable, and certainly more affordable. I was asked recently by a colleague who made the statement, well, you know, life expectancy in the United States is declining. What are you going to do about it? Life expectancy indeed has declined just in 2021 from 77 years to 76.1 years, the lowest level since 1996. If you add that to the 1.8 year drop that we saw in 2020, these are the two biggest year declines since 1921 and 20 through 23. Now, obviously, that decline is huge, but that decline is not equal across all populations. Just like equity, as our last speaker mentioned, has got to be at the forefront of the way we think about organizing and delivering services. American Indians during this same period experienced the biggest drop of life expectancy to 65.2. Compare that to the 76.1. That life expectancy of 65.2 years is equal to life expectancy in this population in 1944. That means, and what we've seen in just this pandemic period has been a decline in life expectancy in this population of 6.6 years. Why do I raise this in this particular forum? I raise it because it's a reflection of what has been called deaths of despair that the United States has actually been experiencing for the last decade or more. That is an increase in annual rates of deaths due to accidents, drugs, firearms, alcohol misuse, and suicides. These are all acts and deaths of despair that have created this crisis that the 988 line is trying to address. And AHRQ is focused on addressing the mental health crisis in our nation that accelerated this loss of life expectancy. We're trying to improve the quality of crisis care and the continuum of post-crisis mental health care options that are available to everyone in our country, particularly through the integration of mental and behavioral healthcare into primary healthcare. Examining the performance of crisis interventions, crisis teams, and post-crisis continuing care that may include other forms of digital healthcare models to reach people in rural and in poorly resourced communities. This focus on improving systems and quality of care across the continuum is central to the research we support and the improvements we hope to help implement here at ARC. Now, the impact of COVID-19 pandemic on mental health is obvious to most of this audience. Over 13% of US adults reported serious psychological distress in April 2020, compared to about 3.9% in 2018, prior to the pandemic. Primary care clinicians are reporting an increase in patients with mental health concerns and substance misuse during the COVID pandemic. And certainly this is part of the reason that 988 has been so successful in helping reach out to people in crises. In June of 2020, 13.1% of US adults reported starting or increasing use of substances. So those increasing use of substances also includes alcohol. Now, ARC's focus has really been on trying to increase the quality of services. And as many of you know, death from suicide has been a major issue for our youth, and particularly our non-Hispanic white adolescents, where rates have risen dramatically. They've also risen quite dramatically in other populations as well, in the Hispanic community and in the non-Hispanic Black community. Excuse me. We face several challenges. At this point, 988 evaluation focuses on process, on how many calls and how many rates of response and our wait times. But more is needed, and which is why I'm making this urgent plea to those of you who are interested in either having embedded health services researchers in your programs or interested in conducting individual research programs. We need to better understand how immediate services are provided and how the quality of follow-up is. Quality improvement in all settings and across all types of services is ARC's current agenda, as described in a series of ARC blogs that is trying to raise the attention of these concerns and these issues. I look forward to working with our SAMHSA colleagues as we develop these programs and efforts. HHS is convening a technical expert panel that's really moving to look at a qualitative evaluation of 988. And I'm glad to say that ARC is serving on the panel, bringing our expanded experience from our CAPS program, which is the Consumer Assessment of Healthcare Providers and Systems program. Several years ago, mental health system services were excluded from our CAPS program, but increasingly we are collecting data both at the primary care level and in the inpatient setting on consumer experiences with mental health services in these settings. So I encourage those of you who want to learn more about what's going on and investigate that and provide the kinds of evidence that we need to make improvements, to look at these data and to use them and to assist states and local communities in the provision of these services. I see great opportunities through the 888 to reduce disparities by making services more available. And certainly the kinds of issues that we need to address have to do with how many of those services get, the language gets translated, for example. I remember as a health services researcher having a difficult time translating concepts that were developed in English, simple concepts to understand depression and anxiety in children and adolescents that from my community made no sense. But we've made great advances in the last 25, 30 years. Those aren't the issues. The issues are now, how do we get this information and collect this information in a way that makes it available for quality improvement in our programs. We increasingly need to work on our improve data systems. And 988 provides this great opportunity for us to develop those systems and to better understand the effectiveness of 988. I'm hoping that at some point we'll have proposals from those of you who are interested in looking at the quality of the services that are provided directly through the 988 call system. As you saw earlier in this symposium, there's 3 phases. There's the immediate response, there's the crisis team, and there's also the follow-up. And in all 3 stages, we need to understand the quality of services that are being provided, and that can only be done by ingenious projects and works that you in this audience can offer and that we can provide support for. So I encourage you to consider us proposing studies and projects that will help build the evidence base that's necessary to improve 988 and to expand its capacity to care for people throughout the continuum of their service needs. Thank you.
So good afternoon. I'm delighted to be here. My name is Andrea Dennis, and I am maybe a little bit of an oddball in this group. I am not a healthcare or mental health care practitioner, provider, researcher, or policymaker. I am a recovering lawyer, now law professor at the University of Georgia School of Law, where I serve as an associate dean and a professor of law. So here I teach and research in the areas of criminal law and procedure, criminal defense lawyering, and as well, more particularly, similar topics related to juveniles, including juvenile delinquency and status offending, as well as child welfare and family law. Prior to entering academia, I worked as a lawyer in the fields of child welfare and criminal defense. I was generally asked to talk with you all today about the intersection of 988 and 911, or as we might think, the intersections between the criminal legal system and the mental health care system, and maybe more particularly how we can think about shifting care from the criminal legal system to the mental health care system, and as well how we can think about systemic racial injustices in both of those systems. So when I was invited, I was absolutely delighted to participate. I embrace and strongly support interdisciplinary work in systems work, and it's not often that lawyers and legal academics get invited to these types of conversations. It was also apparent to me that lawyers, legal academics, we could take this general topic in quite a number of directions. And so ultimately determined that what I want to talk to you for a few minutes today is about one particular topic, which is I think maybe a significantly important one, which is step 1, right? The initial contacting of 988 and reporting barriers and challenges. So who might be reluctant to call 988 because of legal implications that they or others might experience, whether criminal or quasi-criminal in nature, right? Obviously, 988 is quite a valuable resource. We want individuals to call and text, whether for themselves or on behalf of others, but we need to recognize that there are certain individuals who might not feel comfortable or safe in doing so. So in the remarks today, I'm going to rely on a number of different sources or perspectives. So part of this information relies on my professional experience. As I indicated, I practiced as a lawyer for a number of years. I spoke with my clients, their families, their friends, their employers. And so I had many instances of hearing about hesitancy in regards to the criminal legal system that I think translates as well to the mental health care system. I've also done my own research with respect to encouraging individuals to report, in particular, intimate partner violence, and trying to ascertain whether individuals might be discouraged from reaching out to law enforcement or other service providers. And I've also looked at other legal literature on that particular subject. And as I said, because I do embrace interdisciplinary research, I have looked at and do often rely on social science literature and data. So those various sources are informing the comments that I will have for you. So just let me begin by saying, as we all know, and we've heard, callers to 988 might be individuals who are in distress, right? In some form of distress or on a continuum, less distressed or very seriously distressed at the moment of being suicidal. But I also think it's important to recognize that there might be individuals who are calling on behalf of others. So interested third parties might be calling on behalf of someone who is in distress. So whether that's a family member or a friend, an acquaintance, an employer, or some other professional, such as a mental health provider or a physician, and as well, maybe even a stranger. And so what all of these individuals might have in common is that they're part of a vulnerable population. So whether it's the individual who's calling or because they are in distress or someone else on their behalf, these individuals might be from vulnerable populations that might have some hesitancy about calling 988, just as they might have about calling 911. And so the populations I have worked with and researched include those, obviously, who have mental health concerns or mental illness, those who use or misuse or abuse substances, controlled substances or alcohol, those who are criminally involved or have a criminal history, those who are incarcerated or formerly incarcerated, individuals who are undocumented, individuals with disabilities, BIPOC persons, so Black, Indigenous people of color, English speakers of other languages, LGBTQ, minors, so children and adolescents, and then maybe lastly, the two I would mention would include the elderly and those who are intimate partner violence victims. I know that that's a long listing, right? But there are many different backgrounds and experiences that might lead individuals to be what we in the legal community will talk about as vulnerable populations with respect to criminal legal system or other systems exposure. And again, of course, we should recognize that there might be intersectionality. So an individual might have multiple backgrounds that influence or inform their experience or their perspective. So I've worked with and researched and thought about all of these different communities and populations. And I think there's a lot to be understood about whether or not they might use, call, or text 988 on their behalf or on behalf of someone else. And so let me just turn to what I think might be some of the concerns, generally speaking. So these I've characterized them as reporting or informational concerns. And what I'm trying to think about here is what information might be used or collected and or shared in a way that can lead back to the individual caller and or lead ultimately to negative outcomes, which I'll talk about in a moment. So there are, in other contexts, many of you are quite aware, I'm sure, mandated or discretionary reporters, whether by ethics or by law statute. So some physicians, right, or should I say physicians might be obligated to or have discretionary ability to report certain types of injury. Child abuse is one that comes to mind in particular for me, right, but also in partners of intimate, victims of intimate partner violence as well. Teachers might be mandated reporters, those who work with children, maybe not even in a school setting. Law enforcement might have some reporting obligations. So there are the possibility that information will be reported regarding an individual in mental health crisis by another party, either mandatorily or discretionarily. Right. Some of the other concerns might be that if the individual calling doesn't understand that 988, it doesn't use geolocation. I know that was mentioned earlier, but individuals may not understand that they're not necessarily being traced in terms of geography with a mindset towards the ability to necessarily send someone out immediately, right, to help them, or that calls are not necessarily routed automatically, right, to 911. That as was mentioned, there might be a referral or transfer to 911 as appropriate, but some people may not understand that there is not an automatic geolocation or routing or referral or tracing back to the individual so that they can be reported to 911. And if they don't understand this, they might be resistant to calling 988, just as they might be resistant to calling 911. There might also be concerns about anonymity and confidentiality. I think some individuals expect that if they call 988, that the call that they can maintain their anonymity if they're reporting or about themselves or another individual. Similarly, they might have expectations of confidentiality, maybe even if they do provide their name and other identifying information, right? They might expect that it is confidential. Or they might expect that it would be shared, right? Which leads to my last point about information sharing, right? Individuals likely have questions or concerns surrounding information sharing, right? You know, whether the information can be shared with other healthcare providers, whether it will be shared with law enforcement or the court system, whether it will be shared with other systems such as the child abuse and neglect system or immigration. And so those are concerns that I think that individuals might have, right? So again, right, some of what might come up for individuals in some is that that some individuals might be mandatory reporters or discretionary reporters if they provide certain information. So they must call 988 or 911, whether or not their information will be used to be traced back to them by law enforcement or maybe even prosecutors at some point, whether or not their information or their name or identity can be maintained confidentially or anonymously, and then who is going to share any information that's provided later on. So once we then think about those particular aspects of calling or texting 988 that might be problematic, we also want to think about what are the particular negative outcomes. I think for some individuals, there's no particular hesitation. They're seeking help and they're not worried about any collateral outcomes, but others might have in the back of their mind that if I call 988, it's not just that someone will be connected with mental health services, it's also that other systems might be invoked, leading to negative consequences. So one might be quite expected, which is involuntary mental health commitment or inpatient treatment. There are likely individuals who would expect that that could be a result of calling, and they want to prevent that for themselves or for another party. Something I'm quite familiar with is any concerns about criminal exposure or juvenile delinquency, right? So if an individual calls 988, right, and indicates that they are in distress or they're witnessing someone in distress, right, could that lead to law enforcement being called at some point? And even though we understand or we've been advised that it's the rare instance in which 911 or law enforcement is necessarily called out, that the preference through this new hotline and systems is for mental health providers to respond. Some individuals might worry that their information could be shared ultimately with law enforcement or the juvenile delinquency system. So individuals who are on probation and are expected not to be involved with substance use or misuse or abuse, individuals who are on community supervision and not expected to be associating with other individuals, right? Or maybe it's just a concern that calling 988 will signal that there's trouble. And so then that will create either new charges or violations of current community supervision in the legal system. There are individuals, and particularly those who are undocumented, who might worry about being taken into ICE, immigration enforcement custody, right? So individuals who are undocumented could be subject to removal and deportation if there's information sharing, or somehow their name or identity becomes revealed to immigration authorities. So that might be a concern. Similar to those who are concerned about criminal delinquency exposure are those youth who are homeless or runaways, or throwaways, right? Those who have been deemed truants, right? So those youth who are have status concerns might be concerned that they will be reported to their parents or to the court system. Kids could be concerned that either they or their families will be reported to the child abuse and neglect system, or parents might have that concern, or any other reporter might be concerned that by calling about someone with mental health distress, the family could become involved in the system. The same for the elderly, right? I think is probably a population we don't think about as much, but the elderly, if they are reporting distress, might have concerns that they could be taken into guardianship proceedings, which are similar to child abuse and neglect, the idea that the state needs to have custody over an elderly individual to ensure their safety and security. And then lastly here, let me just say a little bit about personal safety or educational professional concerns, civil suit. In other words, some other types of exposure that don't necessarily derive from the criminal legal system or quasi-criminal systems. So, for example, an intimate partner violence victim or a child abuse victim or someone who's elderly might be concerned about repercussions from a family member or a friend or the alleged perpetrator, right? We know in the context of intimate partner violence that when a victim reports, that is often a more unsafe time. Once a perpetrator is aware of the reporting, there could be even greater repercussions. And we could see the same here if information is shared with alleged perpetrators. And then individuals might worry about civil suit exposure, right? And so we have seen in some contexts that individuals are concerned about calling for help on behalf of others because they might be worried that they could be sued either for wrongly reporting or sued for some other negative consequence. And so again, I just want to itemize and explain that there could be quite a number of negative outcomes that individuals might experience. Even though we understand that 988 is not designed for and not meant to create these negative outcomes, it may be possible that in some instances these can arise, or even if it is unlikely that these negative outcomes could arise, individual callers or those calling on behalf of others might be concerned, and so therefore might be less likely to call 988 and seek help. So if I can say maybe just a little bit, and I don't have any really good answers at the moment, I'm happy to take questions at the end. We'll have plenty of time for questions, but I do think there are lessons that might be learned from other reporting contexts. So of course, I've talked especially about my experience and research with respect to calling law enforcement or calling 911, right? As I indicated, I've also worked in the child abuse and neglect system and done research in that system. And these challenges and concerns have also been confronted by that system as well, in terms of who might be a mandated reporter, who's a discretionary reporter, when do they have to report. I understand there are also ethical obligations, but there might be lessons learned for policymakers and practitioners from that particular context or system. The same can be said for intimate partner violence and family violence, right? That system has also long dealt with individuals calling for support and assistance. And then for those who are victims of sexual violence, that particular reporting context could be looked at. And then finally, but it's probably less likely, or there might be less information, is those who are obligated to report gunshot wounds or drug overdoses, right? So any practitioners or researchers or policymakers who've looked at reporting challenges and barriers in those contexts might also have information that can be provided here. So thank you for your time and listening. I recognize that I've essentially problematized this. I've tried to present a number of different challenges and concerns that should be looked at and thought about, expecting and hoping that as 988 continues to develop, that these will be looked at and talked about and hopefully good solutions provided.
Thank you. So I'm Cheryl M. Boyce, and I'm going to be your moderator And we've really explored a lot of different issues at the big picture level, at the federal level. And we're going to have 2 sessions for this really important discussion on 988. And I wanted to make sure you know that so that you can come back on Monday. And some of the questions are really at that level. And so I just want to give a little preview and say that we are going to be looking at some of the more local issues on Monday. So tune in for that. And if you can't make it, it will be recorded. I'm at the National Institutes of Health, and I'm within the Office of Strategic Coordination, which is fondly called the Common Fund. And I'm the Assistant Director for Re-Engineering the Research Enterprise. Our speakers today brought up a lot of interesting issues, everything from financing, legal, and just really how important in terms of 988 is, and the transition to having this type of service in a different form in terms of text and using a different phone number, which will make it more accessible to many. And I want to thank our speakers today for their talks, and thank Margarita Alegria for spearheading and working with the team at the National Academies to bring us all together. With that, I'm going to start with some of the questions. Some of these were more specific in terms of, like I said, the next seminar. So we'll save some of those. But I wanted to kind of ask, I'll go right back to Andrea, because in terms of recency effect, I think it would be great to start there. In terms of retaining sensitive data, that's a question. Are there any situations where there's a need and one is allowed to retain sensitive data? Are there any cases or situations regarding, let's say, this 988 that makes sense, or maybe related case laws or situations that you've seen in terms of legal implications for saving data regarding suicide or harm? Andrea Dennis?
Thanks. I think that's a great question. And this is why I mentioned that I'm a bit of the oddball. And so I am learning, like many of you, about 988 and its implementation and operation. And so I do expect, and I'm sure that others here could answer more directly, but I do expect that 988 does ask for information, identifying information in order to make referrals for services, or in the appropriate instance, send out a mobile crisis team. And so I do expect that there is some information collected. Someone might be able to better answer whether that's with or without the individual's consent. I'm sorry, let me just make sure.
And I say, Anita, you've turned on your camera. Could you maybe unmute and maybe add something to this discussion? Because I do think it's important in terms of balancing legal responsibility, privacy, and as well as safety and harm.
I'm sorry, let me just say one more thing. I think even regardless of what 988 actually does in terms of collecting and disseminating and information sharing, there's also just the concern that there might be a perception of what 988 does, or a misperception that has to be addressed.
Well, thank you.
And I was going to actually hope that Laura could answer that, because much of the call interface goes by protocol, and the intention is to have it de-identified to the extent possible, the data that's actually collected. So that's one part of it. The other parts of the system, if you think about, mobile crisis response or the crisis receiving center, are set up largely as clinical services, in which case HIPAA laws would apply. The privacy protection that goes along with HIPAA would apply to those sort of largely. But Laura, I don't know if you want to talk a little bit about the efforts in the call interface.
Yes, happy Laura Evans, could you respond? That would be great.
Yes, thank you, Laura Evans from Vibrant, the administrators of the 988 Lifeline. And so I do think that there is that perception, Andrea. So I want to share kind of what actually happens and what is the case. So an individual does not have to share any information about themselves in order to receive service. And I do want to also make a distinction, as you noted in your presentation, between anonymous and confidential. So anonymous is that we could never figure out who you are, versus confidential. There may be information either that the individual or their loved one has shared, or items like their telephone number that could be used to identify a person. So people contacting 988, again, you are not required to share anything about yourself or your loved one in order to receive that service or have that crisis counselor work through and provide intervention. Any information that is obtained, we do protect privacy, and any demographic information is sort of for three purposes. One, to ensure that we are saving lives, keeping that person safe. And again, either in most cases, like 2% of contacts do require public safety or a transfer to 911 to have someone go out. In the majority of those cases, that individual has worked with the counselor and has given their consent, provided their address so that 911, the mobile crisis team, can find them. So that's kind of primary use, number one. Number two, to connect that person to ongoing supports. As noted, you're routed based on your telephone number, which may not be where you exist today, right? Many folks have cell phones. So where you first registered your phone may not be where you currently live. And so in order to connect you with ongoing services in the area that you live in, that is why, that is one reason my information may be shared and used. And then the third is to evaluate our system performance and needs. And we partner with Columbia University for that. And so that we can confidently say, 95% of the people who contact the Lifeline say it has helped them feel more connected, and it has contributed to them being safe and alive at that point. So those are the three reasons why we do use data, but certainly there is that perception, and we want to work with communities so that they know what is actually happening.
Thank you. I think that's important in terms of the community and working with the community. I wondered if any of the speakers could share their thoughts on some of the trust issues with communities. We have some questions that are looking at this dynamic and asking about the dynamic in terms of sending out and the differences between sending out someone from the police. And that, of course, brings up issues of trust within communities and how you are essentially deciding and what are the implications of 988 and sending out those police or those who are responding to the calls and resources in the community. And that has a lot to do with the trust that is required when you have a 988, because that's important. And I don't know if you could speak to that, Nita, and maybe some of the other speakers on the panel.
Sure. Yeah. I mean, just to give context, by far and away, based on information that we have so far, and by so far, I mean, over these years of these 19 years of service with it, the calls are effective in addressing the majority of issues that are called about. So it's not the case. It's not the majority of calls that need any kind of other additional mobile response and or a recommendation that a person go to a particular place. So that's one important aspect. That being said, that's hard to message because we know there are communities that have a lot of historic and current reason to mistrust the idea that they won't call 911, for instance. That's known because of who might respond and the adverse outcome that could happen when you call 911 and police responds, and it's the risk is high or perceived to be high of having a really bad bad interface. So we know that's a problem. One of the other ways that we're working on that is to work to have a fairly good sized information campaign that would have a focus on particular groups that we know, subpopulations or groups that may need somewhat different messages. There's not a one size fits all message that works for differences in the demographics that are geographically related to the way our country population is spread out in certain areas. I don't know, Laura, if you've got anything on that one either that you wanted to add into what the vibrant component is. So the vibrant component, we're hoping to have that be, neutral or sort of accepted as a friendly resource to everybody. And the calls themselves, one other thing I want to contrast compared to 911 is the 988 call is not a triage call. It's it's a intervention when the person calls. So 911 is very much triage. They're, hello, 911, what's your emergency? Bam, something else gets deployed. 988 is not that way.
Yeah, and I'll add too for our role, we have committees, steering committees, we're actually retooling them so that we are better incorporating individuals with living experience, loss survivors, attempt survivors, family members, marginalized communities, because we know that there's historic mistrust for many of these communities. And we want to, again, partner with the communities, have authentic communicators so that they know and have someone that they trust vouching for the service and making sure that we're not just saying these things about the service, but the actual service delivery is culturally competent, culturally crisis counselors are showing that cultural humility, that they have crisis counselors that represent individuals from that community. And I think all of that is really important. So we, still have work to do, but welcome partnership with many organizations on that.
And
And
I
I'll
see
just
Mary
add-
has something to add. Yes.
I'm just going to add from the financing side that we have to finance that, right? And so we saw some appropriations increases this past year, but it was a conglomerate, right, for all the needs. And there are a lot of needs. And so I think that we will be talking with Congress and others about the need to really fund the research that's needed, because different communities have different trust issues. And so we need to really drill down onto what those issues are. And then we need to message test, because many times, what people think is going to resonate doesn't actually resonate when it goes out to the people for whom that message is intended. So all of that work has to be done. And then a campaign has to really be launched to reach all the folks that need to be reached. And so I think there's more work to be done articulating all those pieces and ensuring that we sustainably finance that.
And I think I wanted to hear Brian Sims gave us some example of in one state some of the work on thinking about messaging and messaging to different communities. We have a very diverse nation, diverse in terms of languages and diverse in terms of cultures. And I'm not sure in terms of how much is allocated to the marketing and the messaging that will reach those different communities. And maybe Brian, you could speak a little bit to what you think it will take in terms of the dissemination in order to reach the community. Mary as well.
I think Laura answered very, very well with regards to the efforts that are out there, but it's kind of a timeline issue, because when you look at SAMHSA's efforts and what we've been doing to get it started, it actually was begun at that level. We were communicating already with the communities and getting the community individuals involved, and it could be from various aspects. You could go into, for instance, the faith-based community, and you could speak to the faith-based individuals about 911 implementation. They are then trusted individuals by other members of the community who can then get their information from that source, and that became more of a trust issue. There are a number of states that are doing it through barbershop therapy, where they actually have promoted the 988 usage through barbershops, and everybody drops in and they all learn about it. So there are various ways, and like Laura was saying, to get the message out there, but the key is you want to make sure that they're involved in the conversation, because its implementation is not simply something to say, July 16th, we started and everybody's going to be on board. As you can tell, those who don't trust won't trust on July 16th any more than they trusted beforehand, or even afterwards if you haven't talked to them directly.
Right. That's important. Did anyone else have an addition on that? Okay. So there were some questions specifically about, I think, Asian American populations and thinking even about territories and some of those smaller nations and territories of the U.S. and specific outreach. So I think that's a concern that one of our Q&A commenters brought up. So I think that is something of that in terms of that time, it's going to be something that we have to think about. This is still rolling out, and we're addressing those who were using the previous hotline and thinking about now engaging new users and new approaches in terms of implementation. There's also a question here a little bit about thinking about how we're in a new time where we want to keep people out of the emergency room. And of course, with the impact of COVID and keeping people out of the emergency room and how we can think about different strategies and incidences. Can you speak a little bit to how you have any data or thinking about approaches that where 988 has been able to really work in terms of keeping people out of other service areas and emergency rooms, and how we can maybe impact that in new ways within 988 framework? Do we
I
have
was,
that?
I was going to say the data is emerging, and I don't know if Vibrant has more access to more recent data, but in states that have, we have 50, one way to think about our healthcare system in the United States is it's 50 different major states, and then we do have territories and other, components that we work with, and they are recipients of the block grant, by the way, which has that crisis set aside. So all of those entities have some access to, Guam, for instance, had one of the TTI projects that helped them build one of the workforce development projects related to crisis services. So there are, it's smaller and smaller populations areas, but anyway, there's sort of that that focus to, or that opportunity there. I do think it's really important also, just so we do what I started to say, I apologize. Some states are more advanced in their, conceptualization and building out of those three components. And in states that have fairly mature systems built, really, and harkening back to a point Mary made earlier, the real answer is having more services available earlier in the spectrum in the community so that we don't need, as many things. But some states that have well-developed systems have demonstrated reduced use of inpatient stays and reduced use of incarceration rates. So we don't know if that's going to hold up in all the other states. And Brian, you may know with your finger on the pulse of what's going on in states more, it's closer to the action than I am. But we have a lot of hope, a lot of good reason to have hope that that's going to be the case, that we'll be able to reduce higher level care that's avoidable by having earlier interventions, earlier access.
Yeah, not only do I completely agree with everything that you've said so far, but I also wanted to go back to the Pacific jurisdictions, because that question talked about those particular factions. And in contact with them, it's been a most amazing positive movement forward, because what we've seen is that places like Palau and looking at Guam and some of the other areas, they have a network amongst each other where the strengths are actually promoted, and we've learned from them in terms of their provision of care, because as you said, one community is simply one community. And looking at those smaller populations that get a very small chunk of the money, their unique ways of kind of utilizing that service to ensure that it gets out to all people still has some parallels where they look at how they advertise it, how they ensure the trust, how they work with others. And I don't know if this is going down the road of answering the question that the person placed in the chat box, but there are a network. As a matter of fact, they just had a meeting in Hawaii last month of the Pacific jurisdictions to specifically speak on the 988 implementation components in their various jurisdictions. So to call upon that as maybe a resource to see what kind of wonderful things are coming out of those efforts.
Well, that's great. In terms of all these efforts, one thing you just mentioned was that some states and some places and some communities are doing, are able and have some best practices that are they're further along than others. Do we know of some efforts, or are there ways to really connect those best practices so that other communities can learn from them? I mean, how can we get community to practice, or how can we do that, especially with some of these new ways emerging? I know that you're probably already thinking about that because everyone's nodding. So I'm sure a lot of people on this call would love to know about that.
Well, Cheryl, I will share this with you. I was kind of smiling because we have an adage at NASPIT, and it's called brag and steal. So when we talk to various states, we talk to them about the positive components that they have, and then we let them know that we're planning on sharing that with other states. Because as you said, there are many places that really want to know what's going on. And I guess the positive piece, as Anita pointed out, is that the states are anxious to share their information. And they are easily connected, where you can talk to them, they will share their data with you, they'll share all of their outcomes. And with the understanding, of course, that this is what works in their state. So you may
Okay.
find some pieces of it that are helpful. You may find all of it to be helpful. There's some amazing work going on in Alaska. And when you look at Alaska and you compare it, well, maybe that's not going to be like what I have, but there are certain components of it that can be extremely helpful. But I think the connection has always been the answer here. It's just using that collaboration.
Is there financing or infrastructure to help communities do that? Because I hear what you're saying. I mean, it's great that people are usually open to sharing, but I wonder, is there a way, is that part of some of the work of the agencies or the center? And Mary, I don't know if there's, in terms of even sharing ways in terms of strategies for additional financing, and is that any component right now, or is that in the works?
So there is a technical assistance center in the works because the Congress passed a statute requiring that, and it will definitely include financing strategies that's specified in the legislation. There has been some guidance put out by CMS, particularly around the mobile crisis opportunity that I mentioned in my presentation. I'll put in the Q&A. There are several reports that have looked at best practices. CLASP did a report on youth mobile crisis as an equity issue and gave some examples of states that are doing a good job there. The Vera Institute did some work talking about different crisis systems. Going back to what you said about prevention, in Washington State, they have in one community a peer navigator team that goes out and tries to work proactively before anybody experiences a crisis as part of their continuum, along with their mobile crisis, along with the work that they do with law enforcement. So there are examples, and I know due to the legislation, there will also be a compendium of effective practices, but there are existing things out there now as well.
And Cheryl, if I could also add, this is Laura Evans again. Even before this transition in July, Vibrant issued state planning grants for states to convene stakeholders, again, individuals with lived experience, policymakers, the whole gamut, to begin to survey the landscape in their state for those three prongs of the continuum. What gaps existed? How were they going to coordinate those pieces? And we are very thankful that SAMHSA has since launched their state grant program so that states can receive additional technical assistance and receive funding to continue that work. So I think this is, again, just the beginning of the marathon that we have towards that vision that we share for better serving people and diverting from crisis to begin with. But I think, as Brian mentioned, it's going to be every community has different needs. They may set things up differently. And even within a state, jurisdictions may do things, counties and cities may do things a little differently. And I want folks to not feel any angst if they don't have a crisis center directly in their city or their county, because your state, as long as it has capacity, may only need one center, as long as it has that capacity to answer the contacts and a really strong resource referral database. Or it may be like California that has 13 centers spread out across the state. So again, there's no one size fits all answer to many of these questions. And so it really is about plugging into the conversations occurring, in your local jurisdictions.
And when you say jurisdiction, that just reminds me, and I think it's great that you brought up some of the issues, Andrea, in your conversations, but whether they're laws and jurisdictions, there's really a body of ethics. We are talking about mental health issues, suicide prevention, and I hope that we start to really, in that body of practice, and as we really are, we're going to texting and thinking about moving forward and growing. We also develop a body of ethics and things that will help those who are manning these lines and making decisions and in their work. So I hope that work is you were very thoughtful in that way. I hope that there's bodies of work in terms of the ethics as we move towards. I think the mobile platforms are going to be an important area as well. And I don't know if you have any closing comments, Andrea, on that, but texting and those kind of things, and the aid of who's calling. And someone did bring up, when you call for someone else, that's also something to consider. Any thoughts, Andrea, as we close on texting and the ethics of mobile and people, anything on that?
So I've got lots of thoughts. I
A
do.
summary thought, because we're about to close and turn it
Yes,
over.
no, I won't share too many, but I do think it's important to think about training both for those who are acting as the recipients of the call and taking the information and making decisions about whether or not to send out a mobile crisis team or law enforcement. But it's also important for those who might be reporters, mandated reporters, to give them education and information about their ethical obligations as well as their legal obligations, which may or may not be coextensive, and just understanding the differences between those and what the implications might be. So I think there's a lot of to be done in that regard with respect to ethics and in relation to law for everybody involved in the system.
Well, with that, I want to thank our panelists, and I'm going to turn it over to Howard Goldman. We've had an interesting discussion and wonderful presentations, thoughtful presentations, as we really take on an important issue that saves lives. And I want to thank you all for the different parts that you contribute to the conversation and to 988 and the work that you do. Dr. Goldman?
Thanks, Cheryl Boyce. And thoughtful indeed. I'm Howard Goldman, and I'm here to make a few closing remarks, very few. I'm a professor of psychiatry in the School of Medicine at University of Maryland at Baltimore, our country's first public medical school. I've been serving as the co-chair of the Forum on Mental Health and Substance Use Disorders with my friend and colleague Maggie Allegria, who kicked off this webinar. And the Forum is directed by Ali Andrada. And I've been pleased to be involved in planning a number of these webinars on 988 and participating in them. And I'm just amazed. There's always something new to learn about it. And I've been struck how much we need the field to learn about 988. There still are many people involved in clinical service delivery who are not really aware of 988. We need to do our best to spread information about this important new lifeline and crisis response system. We can't hope to reach the public if we can't reach our own field. And I think agencies that are represented here among the presenters are doing a really fine job, but more work is clearly needed. After presenting some basics on 988, this particular webinar focused on two main themes. The first theme was related to resources and financing, both of those that are important in initiating 988 and crisis services, and very importantly, those that will sustain this system after what might be one-time funding disappears. And then the second theme is related to equity, whether it's related to minoritized populations, stigmatized populations, connection to the criminal justice system and the police. That's the second theme that I wanted to call attention to. As has been said by several of our presenters, this is the first of two webinars. The second webinar will take place on Monday, the 23rd of January in the same time slot, which is 12:30 to 2:30 Eastern time. It will feature additional examples of state and local 988 implementation, both challenges and best practices. I say additional because several of our presenters today offered state examples that are illustrative of one point or another in implementation and sustaining services. So by the time the two webinars are complete, I think we'll be able to do what Brian Sims characterized as have plenty of bragging and plenty of stealing to go around. I did want to note that the National Association of State Mental Health Program Directors and its Research Institute, on both of their websites, there are a host of reports related to 988. I was contacted by Ted Letterman at the Nashville Research Institute, who said that just yesterday they put up a whole series of reports. So I called them to your attention, and I believe that Ali Andrada and the staff at the National Academies are making the links available. We view this series as an organic whole, and so we certainly try to cover the topic from many angles and hope that you'll join us again on Monday for the second part of the webinar series. You should know that a recording of today's events, along with full bios and presentations, will be posted on the webpage in 7 to 10 days. Thank you to our distinguished webinar participants. It was good to see many of my friends and colleagues in this array. Thanks to the working group that planned this webinar series and to the staff at the National Academies who support the activity and without whose efforts this just wouldn't happen. Thank you to all of you who've been viewing the live stream, sending us questions and comments, and we hope to see you on Monday. Thank you.